Funding for this program is made possible by the Corporation for Public Broadcasting, Louis B. and Louise Hirschfield Coleman, Sue and Edgar Wackenheim III, and contributions to participating stations. Coming up, a high-tech research clinic with a mission to help veterans manage PTSD.
The treatment is most effective when we can tailor the individual scene to the veteran.
And smart dummies train military members to save lives.
The SimMan 3G simulates actual trauma scenarios that these airmen could face in combat.
Exploring the frontiers of science. Probing cutting-edge technologies. Seeking answers to the big questions. Welcome to SciTech Central. 2.7 million troops have served in Iraq and Afghanistan. Nearly 1 in 10 return home with some form of post-traumatic stress disorder. At the UCF Restores Clinic, researchers are working with virtual reality technology to develop innovative treatments to help these veterans reclaim their lives. When Stephen Cotta was deployed to Iraq in 2009, he was a young man excited about the future. When he returned home a year later, he was reclusive, aggressive, and angry. Cotta showed the classic symptoms diagnosis of post-traumatic stress disorder.
I was in a very, very dark place, and it was very nerve-wracking to me to feel that lack of control, to where I felt like I was powerless over something because I was no longer managing my life. My life was managing me.
Cotta's life path changed, however, when he sought help at UCF Restores, a clinical research center at the University of Central Florida's Psychology Department. It helps veterans with PTSD to cope with life's challenges. One form of treatment offered is exposure therapy using virtual reality technology.
Exposure therapy has been around since the 70s, and what we've done is supplement it with virtual reality equipment such as sounds, smells, as well as virtual reality images that'll help the veteran get more in touch with the traumatic memory. These memories are often very traumatic for these veterans. And so what the virtual reality does is they're all the sounds of war, the smells of war, the visuals of war, and that helps them get in better touch with that memory so they can learn in a safe environment how to adjust to them. Unfortunately, a lot of the incidents that the veterans experienced were in vehicles for IED explosions. The treatment is most effective when we can tailor the individual scene to the veteran. And again, this treatment's about being able to do the scenario over and over and over again until the veteran can learn a better association with that traumatic memory.
Cotta is one of over 150 veterans who have undergone exposure therapy at UCF Restores.
I was very nervous, very excited. It was a mix of emotions for me, you know. It can be very frightening coming into something that you know is gonna force you to go back to somewhere you really don't want to be at, you know.
So I want you to think back in February in 2009 when you were back in Iraq. And so you remember going on patrol, and what happened next?
Once we departed the staging area, we were headed west on a side road, and we had passed our last truck, and we had entered into the field. We passed the wall. What it is that's great about this program is that it shows you how to handle and manage yourself, because really you're kind of just like a lost child when you're before. Prior to this program, I was having a lot of issues with my post-traumatic stress, and I think that it was mostly a lot of fear. I was very afraid that no one could help me and nobody could understand. So when I was in the virtual reality, it showed me that I can do it myself. Once we were about halfway through the graveyard, we received small arms fire from the southwest corner. Immediately hit the ground and was scanning my sector and just trying to see any type of positive identification from the building where we were receiving the fire. At the same time, a lot of communication was going on.
When we talk to our veterans when they come into the program, we tell them that, you know, this memory is never going to be something pleasant. It's never going to be, you know, something that's good to think about. But what we can do is help reduce a lot of the pain and a lot of the anxiety that comes up when you think about it.
And my best friend's truck was hit with a hand grenade. And when that hand grenade went off, I can remember being extremely frightened because it was my closest friend's vehicle. You have to completely immerse yourself in it 100%. and you have to give every piece of your soul because it's the only way. It's really nice to have people, you know, like to do something for yourself and then have people who care. Staggered column across. I can't explain the feeling that it gives me.
Benjamin Trachik believes if a veteran is comfortable with virtual reality technology, it's easier for them to seek help at UCF Restores.
Veterans, especially the younger veterans, have a lot of experience with this technology, and I think that it is helpful, to have them come in the door, and that can often be the hardest part for a lot of veterans is to admit that there is an issue that they need help with, and anything that we can do to be able to make that transition a little bit easier is what we want to do.
No, because I needed to keep my eyes out, and I needed to make sure that I was keeping my security and making sure that there were no secondaries coming.
Kata knows there are no easy solutions to PTSD.
One thing about post-traumatic stress disorder that people get very confused, it is not something that is curable. It's not something that's going to go away. It's going to be with me for the rest of my life.
But through this new treatment, Kata has something he hasn't had in a long time.
This program gives you tools that you never knew that you had before. It helps you to overcome so much stuff. This program literally saved my life. Success just means having a manageable life and being able to be somewhat normal, and not feeling like you're an outcast. Post-traumatic stress disorder to me is my life, and I can't stop because it's not going to stop for me. Every time that I leave this place, I just feel so much more hope inside of me that I can handle this and that I'm going to be okay,
We offer TMS here at the Healing House. It is a neuroscience where we deliver magnetic pulses at a high frequency to the left prefrontal cortex of the brain, and it allows us to stimulate the neurons to connect. So we're essentially treating the source of depression rather than the symptoms.
This is a NeuroStar machine, so we're gonna put him back. It looks just like a dentist chair. And right now we're just making sure we're going through the appropriate metrics. We're gonna be targeting his left prefrontal cortex right here.
It's teaching the neurons to do what they should have been doing all along. This allows us an option to not only help those individuals that don't respond well to medication, but also to allow people an alternative.
A 10-year research study, 14,000 research applicants, 46% remission rate, 75% response rate. So significant numbers with a significant sample size and no side effects is what makes this a holistic treatment for depression.
TMS is an incredible technology or modality, so to speak, that allows us to treat depression naturally, holistically without medication.
For Richard Murphy, a former paratrooper in the Gulf War, parachutes have saved his life in more ways than one. While struggling with congestive heart failure, Murphy received a parachute implant, which helped save his life.
Just out of high school, I joined the Army. I was a paratrooper and I served in the Gulf War. Every time a paratrooper jumps out of an airplane, they're counting on their parachute to open, save their life. And it did on numerous occasions, and I'm quite proud of that.
At age 40, Richard's life was great. No longer serving in the Army, he was running a new business and recently had become engaged.
It was early October. It was beautiful outside. The leaves were changing.
We were in love, had just gotten engaged. He was about a year into his new business and things were very exciting. And then
I started to sweat. I had really tight chest pains.
His heart blocked up 100%, his LAD, which is the main artery in your left ventricle.
The next thing that I remember is waking up in the hospital with a doctor yelling, "Mr. Murphy, Mr. Murphy, do you know where you are?" When I found out I had congestive heart failure and I found out just how bad the heart attack really was, I lost a lot of hope. I spent night and day for almost a year, I think, researching, sending emails to different clinical trials, and then finally found the parachute trial at Florida Hospital, Pepin.
He was evaluated by Dr. Charles Lambert. the medical director at the Pepin Heart Institute at Florida Hospital in Tampa.
Richard was a perfect candidate for this type of therapy. Very, very poor ventricular function and very limited in what he could do.
Dr. Lambert determined that Richard could benefit from the Parachute implant, a new device from Cardiokinetics that is currently going through clinical trials.
Well, the Parachute trial involves an implantable device. It's very unique.
The procedure was done in the cardiac cath lab at Pepin. Dr. Lambert explains how they use the latest imaging techniques to guide them throughout the procedure.
So these images are transthoracic echocardiographic images. On the left side of the screen is pre-procedure, on the right side of the screen is post-procedure. There's a transducer up at this part of the image. This cavity here is the left ventricle, this is the right ventricle. This is the mitral valve, this is a tricuspid valve. And you can see in the pre-procedure image, this particular patient's heart is not really contracting well at all.
After evaluating the heart's efficiency, they use the cine angiogram or X-ray movies to guide them to implant the device in the left ventricle.
These are wires from the patient's defibrillator pacemaker. This is the aorta, or the blood vessel that leads out of the heart, and this is a catheter shaped like a little pigtail. It's injecting dye so we can see the chamber. And then through the leg, a very large delivery system, a catheter system, is brought up over the arch of the aorta, down through the aortic valve, into the very end of the left ventricle.
Animation provided by Cardiokinetics shows a catheter system where the end of the device is placed at the apex or bottom of the left ventricle.
And once we're sure that we're in exactly the right spot down here, we start to withdraw the sheath, the big catheter, a little bit at a time until the device is released. You can see here, and there's a balloon that's inside of that device, and when it's unsheathed and the tines can go out, the balloon is inflated very, very quickly to make sure that the tines actually seat in the interior of the left ventricle. This is all done very quickly because obviously this is holding the valve open, and we want to minimize the risk of stroke or other complications. The balloon is then deflated. Remember, there was a balloon picture in here. It's brought back into the catheter, and the catheter is put back down over its attachment site. We take a picture to make sure that the parachute's in the appropriate device. And if you can see, there's a space between the edge of the parachute and if you look right here where there's dye, where the left ventricle is. A little bit of dye creeps in there, and over time, that goes away. It fills up with clot and pannus formation, and that's really the volume of the left ventricle, which is excluded by the device. And at the end of the procedure, we take a picture of the artery that was used to introduce the whole system up, and we close that off, and that's the end of the procedure.
After the procedure, Dr. Lambert takes another look, using the echocardiographic images to evaluate the heart's function with the new device.
Now, the basic function of the heart hasn't changed, but what the device has done functionally is excluded this whole portion of the left ventricular apex. So that's a dead volume, which now blood is actually not getting to it anymore.
Immediately after the procedure, I was sitting in my hospital room and everybody was making a fuss, and I could take a deep breath for the first time in 2 years. So I noticed the results immediately.
He really felt better, got up, just about ran out of the hospital. So perfect patient, perfect outcome. You know, it'd be nice if everybody was that perfect.
We went from not knowing what the future held and to being pretty grim, and now our future is so exciting.
Cardiovascular disease is the #1 cause of death in the United States.
If there are 500,000 to 600,000 new heart attacks every year, it's a big problem. But a lot of patients there is no option for. So it's a lot of potential patients with potentially a great benefit for them.
And the benefits for Richard and Allison just increased by one.
Well, after all the miracles that we've already been provided, we're having another miracle. My wife is pregnant. We're expecting a little girl.
We've been getting our furniture put together, have a closet full of clothes that honestly we just go in and play with and look at all of it. We're very excited about her.
Yeah, it's pretty amazing that 20 years after being a paratrooper, that I would need another parachute inside of my heart to save my life.
Pacemaker cells are what keep your heart beating at the correct rhythm and ensure that each cardiac muscle cell contracts in coordination with the others, because you don't want your brain to have to send a series of action potentials every time you need your heart to beat. Your brain has got other stuff to do. So pacemaker cells are, in a way, your heart's very own brain, generating the initial spark that sends a current through your heart's internal wiring system, known as the intrinsic cardiac conduction system.
If you've ever taken a CPR class, you're probably familiar with the training mannequin called Rescue Annie. Today, much more sophisticated versions are being used to prepare military personnel to treat battlefield trauma.
Is that the ketamine? Yeah. Okay, so just give 2 cc's of that, the 100 milligrams should be good. Okay, let that go, come up here. We're gonna put both hands on the neck like this. Okay.
These military medical personnel are working hard to stop the bleeding, clear airways, and keep these patients alive. Clearly, these aren't real live patients, but the actions of those tending to their wounds will determine if they survive their hypothetical trauma. Located at St. Louis University Hospital, this is the Center for Sustainment of Trauma and Readiness Skills, or CSTARS.
We bring in individuals, Guard and active duty military members, mainly in the Air Force, to give them 2 weeks hands-on patient care experience.
You got the 2? Got the 2.
Deliberate practice, hands-on experience, and level 1 trauma is key in preparing these doctors, nurses, and medics for deployment.
It is very important because the majority of members of the medical community do not have any actual experience working with patients who have been critically injured or critically ill.
Air Force medics in the Guard in their civilian world may be police officers or even bank tellers, and active military medical personnel may have only worked in clinics. For many of them, working on these critically injured dummies is their first exposure to trauma. And these dummies, well, they're not so dumb.
So do their injuries mirror what they might see in a situation in Afghanistan?
This mannequin, as a matter of fact, he is a TBI, traumatic brain injury. Then we have a third country national child, okay, and he's a femur fracture. The soldier on the end, he is a burn blast patient.
These mannequins, the SimMan 3Gs, are manufactured by Lærdal, the Norwegian company that developed the rescue mannequins used for a typical CPR class. But the SimMan is much, much more advanced.
Sir, can you speak? Can you tell me your name? Check the pulses.
The SimMan 3G simulates actual trauma scenarios that these airmen could face in combat and have physiological attributes that may be monitored and treated. They have breathing, circulation, and cardiac features and vascular access. They have capabilities to bleed, blink their eyes, secrete fluids, and have seizures. Oxygen levels can be monitored. They can talk.
What? I can't breathe.
All while being closely monitored by machines and Air Force personnel.
As the patient is deteriorating, if they take the necessary measures to correct the abnormalities that the patient is having, we can make that patient improve if they take the necessary measures. If they don't, the patient's going to continue to deteriorate and the patient may expire like they did on this scenario.
He died 3 minutes ago.
We don't try to keep the patient alive to make them feel good. We can't do that.
Because that's not real.
That's not real. Patients die. That's just the way it is.
St. Louis University is one of 3 CSTAR locations in the country. The others are located in Baltimore and Cincinnati.
It's needed so much, especially As we get winding down from our areas of engagement, you're going to have more and more individuals with less experience of treating patients like this. So these programs, the ones we have here and Cincinnati and Baltimore, are so much more important to keep individuals spun up on the most current practice guidelines of treating trauma patients.
One Southern California couple is going to extreme measures to revolutionize the physical therapy industry. With a store-bought motion capture device, they devised a way to track the progress of patients, one step at a time.
This is what physical therapy could look like in the not-so-distant future. A motion-captured image of a patient that lets doctors take exact measurements. Systems like this already exist, but the machines cost hundreds of thousands of dollars. A startup company called Precision in Motion is making one using an off-the-shelf Microsoft Kinect sensor and a little software ingenuity.
Microsoft has developer tools, so we took the developer tools and have adapted them to physical therapy.
Essentially what we're doing is we're taking the technology that's already been developed for gaming and three-dimensional analysis of movement, and we're harnessing that sensor and we're building software that will more specifically answer the questions that are appropriate for a physical therapist and adapt to our use of it.
The Kinect records the patient's every movement in a 3D space.
If I am targeting the knee and I want to know how much the knee is moving, the thing that I use is basically my visual assessment of how they're moving that knee. With the Kinect, we'll be able to replay how they walked and slow it down so I can see it in much slower and analyze it. And in addition, on the screen, it's going to show up exactly what the range is at each joint.
The development team says the system is a major step forward in the field of physical therapy. Not only will it benefit caregivers, it can also inspire patients.
With this system, we can project on a screen in front of them so they can actually see what they're doing as they're doing it. So they know that on the screen it says, my knee is 30 degrees and I can push it to 32 and work hard at the moment. So being able to, at the moment, see how you're doing and push a little harder, I think it speeds up progress in rehabilitation.
Today, the standard of measurement at most physical therapy offices is a best guess through observation. At her practice, Dr. Butler is working with Colin, who is a toe walker. She watches his gait to look for improvements in heel strikes as he walks, then has to stop the therapy session to get exact measurements on joint angles.
If I had a Kinect here, I would literally not have to use this. I could literally turn it on, say go, and have both sides right away. Whereas right now, I'm down here on the floor trying to measure, and then I'm going to have to go over on this side and do the same thing.
Dr. Butler believes the Kinect system will allow therapists to make great strides in patient care.
I feel really excited that this could potentially improve life for a lot of people in a lot of different places. I mean, potentially all over the world.
That's all for now on SciTech Central. Thanks for watching. Join us next week for more stories from the frontiers of science and technology. Funding for this program is made possible by the Corporation for Public Broadcasting, Louis B. and Louise Hirschfield Coleman, Sue and Edgar Wackenheim III, and contributions to participating stations.